This is coming from washing cytology of the left renal pelvis. So the patient is actually found to have a bladder tumor, and with the same examination, because when we do the ureteroscope, we will go to the bladder first. So they also sample the specimen from the bladder, and the bladder, we received the biopsy. It was signed out as high-grade urothelial carcinoma, and then the surgeon going up from the ureter to the renal pelvis. When we check the history, the left kidney, this is coming from the left renal pelvis. The left kidney is actually has some developmental abnormality. It's a horseshoe kidney. So it has some developmental abnormality. So when we take a look at this specimen, it is hypercellular, consistent with the washing cytology. And we do see a lot of single cells, and most of them looks like umbrella cells. So it does looks like umbrella cell. And we have scatter of these a typical cell with higher NC ratio. But majority of the cell looks relatively benign and looks like umbrella cell. So when we're dealing with the upper tract, we need to be very careful not to to call the specimen as definite positive. I think in this situation, first thing that the surgeon in the scope, they didn't see tumor. They only see the abnormality of the collecting system, and that can be resulting some reactive type of change. Some of the cell does show a TPR. However, the number is very limited. If it is a lesion and we do washing cytology, usually there will be a lot of more. So could it be coming from the lower urinary tracts? We don't know, because we confirmed that in the bladder there is a high-grade urothelial carcinoma. So I think in this situation we'd better taper down our diagnosis. So originally it was called high-grade urothelial carcinoma upfront. I acknowledge that this cell does looks like high-grade urothelial carcinoma. However, because of this scan cellularity, and the surgeon didn't see the lesion in the renal pelvis, maybe we should just like taper down our diagnosis to intermediate, not just call these high-grade urothelial carcinoma upfront. Okay, so it is important that we correlate with all the clinical feature and not to overcall the cases. Otherwise, sometimes it will have a severe consequence that the patient take down the entire kidney and we do not see anything, and that would be not good. So the next specimen, let's move to the fine needle aspiration. This one is from pancreas EUS guided biopsy. So the patient has a pancreatic tumor. So the biopsy was obtained through the stomach. So we see these highly atypical cluster of cells. So it's very obvious that we can see so-called 4-to-1. In one cluster, the size of the nucleus, the variation is bigger to 4 times. So this is a strong sign to suggest that this is malignant. And we also see that there are some rosette forming, suggest this is a glandular differentiation tumor. So this is consistent with an adenocarcinoma. So there are a few clusters. Here we also see necrosis. So this is consistent with tumor necrosis. So we do see a lot of tumor necrosis, and again here is the cluster of atypical cells with glandular feature. So this is consistent with adenocarcinoma. Then we move to thyroid. So this is the thyroid aspiration. On low power, we do not see a lot of colloid, only the scattered dense colloid. Additionally, we do see some epithelial cluster. So when we see the epithelial cluster, we would like to go to higher power to confirm. So when we go to higher power, this cell does show nuclear features of papillary thyroid carcinoma. So we see this organization, which means that the distance between each nucleus is variable, and the long axis of each cell is crossing with each other. Additionally, the shape becoming elongated. The nuclear membrane is very irregular. You can see some notches here and there. And also, the chromatin pattern is more ground glass. So this is compatible with papillary thyroid carcinoma. When we see the feature like this, we would like to see if the majority of the cell does have this feature, and if we can find some area with pseudo inclusion. Sometimes pseudo inclusion is very difficult to identify, but if the change is diffuse throughout the entire specimen, most of the cell got this type of feature, it is okay that we can make a definite papillary thyroid carcinoma diagnosis. So for this specimen, this is diagnostic for papillary thyroid carcinoma. We do not see a good area of pseudo inclusion, but it is okay. So the second case is pretty similar. Again, we do not see a lot of colloid, but only scattered like cluster of epithelial cells. So again, the cell does looks like atypical, and with these elongation, some grooving, ground glass chromatin pattern. So this is again consistent with papillary thyroid carcinoma. The cellularity and the preservation is even poor, lower in this specimen, but the nuclear features are pretty good for definite call. So we also is going to call these as papillary thyroid carcinoma. So if the liquid-based cytology is not well preserved, we can always check the direct smear. For this case, the direct smear has a lot of cells and with very similar features, so which is good for the diagnosis. So here we do see most of the cell have this nuclear feature of papillary thyroid carcinoma. The background colloid show these very dense, what we call bubblegum colloid. So this is also typical for papillary thyroid carcinoma. So in the direct smear, we also see some of the areas suggest that the papillary architecture. So we see more complex architecture and with some fibrovascular cores in between. So this is compatible with papillary growth. So we have both architectural pattern and the cytologic pattern, and this is good for the definite diagnosis. So a third case is also from the thyroid. This is what we like to see for papillary thyroid carcinoma. We have hypercellularity, and on low power, we do see monolayer sheets, and the decapitated papilla. And sometimes we will see more complex papillary structure. And in the background, the colloid is scanned and mostly in this very dense colloid. So on low power observation, it is already highly suspicious for papillary thyroid carcinoma. And we just need to go to higher power to find a more flattened area to confirm that all of these cells have features, nuclear features of PTC, and this is consistent with papillary thyroid carcinoma. Here we do see a decapitated papilla. The structure is actually throughout the entire specimen. So this is good. So here again you see decapitated papilla. Here seems to be a dense colloid or a pseudomatous calcification, uncertain. Yeah, so this is consistent with, so here again, a decapitated papilla. So this is consistent with papillary thyroid carcinoma. So sometimes in the finding the aspiration, this is a different case. On low power, you can see this is very, very similar to prior specimen. We do have hypercellularity, scan colloid, and a lot of cells looks like flattened sheets, as well as these more complex structure, and with fibrovascular cores. So you can see transgressing vessel in between. However, if we go to higher power, the nuclei do not have features of papillary thyroid carcinoma. So we go to a more flattened area. The nucleus are all very round and with a very smooth nuclear membrane, nuclear border. The chromatin pattern is very condensed, unlike the ground glass pattern that we see. So this is actually consistent with papillary hyperplasia, hyperplastic nodule, and with papillary structure that was sampled by the fundamental aspiration. So the low power is important. However, when we want to make definite diagnosis, the key feature we should go to the high power to identify the nuclear feature for papillary thyroid carcinoma. So for this case, this is signed out as benign, consistent with follicular nodular disease, and this is represent example for benign papillary hyperplasia. Okay. So the next specimen is also coming from the thyroid. So first of all, it is very paucicellular. We don't see a lot of cells. And the cell that we see do have some cytologic atypia. In addition to the nuclear atypia, the cell does have abundant, more dense and granular cytoplasm. A little bit difficult to see through. Yeah, but looks like these. So in this cluster, it is more flattened. We do have a lot of cells with enlarged nucleus, distinct, maybe prominent nucleolus. The NC ratio is low because you see a lot of cytoplasm, densely and granular. And this is consistent with oncocyte, Herzog cell. And we also see binucleation. So in the situation with these oncocytic cells, the cellularity is low. In the background, we do not see colloid or prominent lymphocytic infiltration. In this situation, the specimen is better classified as AUS with Herzog cell or oncocytic aspirates. So the differential for these include, could it be a parathyroid lesion with oncocytic change? Could it be medullary thyroid carcinoma? These need also taken into consideration. We do not see any amyloid material in the background, and the patient doesn't have like the history of um, like a abnormality of serine like a testing. So I think we can still consider this is follicular cell origin, oncocytic change. So we call these AUS with Persol cell or oncocytes. So we move to a parotic aspiration. So this is a liquid-based preparation. In this preparation, we see a lot of background material. This is actually the gel from sonograph. Okay, so this is not from the patient. So we do see old blood, so means that it is bloody with hemorrhage, and there were very scattered cluster of cells. That looks like acinar cells. So these represent non-neoplastic acinar cells. 叮咚吗？是什么？那你先寄回来好了，好，谢谢。So if this is the only element that we see, we will call these category 1 non-diagnostic. We only see non-neoplastic acinar cell, which means missampling. They only sample the normal parotic tissue. However, we need to see the entire specimen, so we move to the direct smear. So in the direct smear, the picture is totally different. So we start to see the cluster of cells and the individual cells with some stromal element. The cell has this oval shape and looks like myoepithelium. So this looks like a myoepithelial rich tumor, and some with this chondromyxoid type of matrix. So I just want you to pay attention to the myoepithelial tumor. Sometimes for the myoepithelial tumor, it is not uncommon that we can see some nuclear atypia. So you can find very few scattered cells with more enlarged nucleus, more cytoplasm, some with the nucleolus, but this is very scant comparing to the background. So occasionally you can see very scattered nucleus with these atypical change. So you need to decide if we want to call these benign or if we want to call these AUS or even SUMP with differential diagnosis suggests that could it be carcinoma ex polymorphic adenoma. So for the myoepithelial rich lesion, we always want to see the Lewis-Stan. So when we go to the Lewis-Stan, we do see nice, like a magenta color extracellular matrix with a very indistinct feathery type of border. And if you take a look of the stroma, you can see the myoepithelial cells has very close relationship with these stroma. So this is very typical for a pleomorphic adenoma. So if this is the background, the majority of the specimen looks like these. Very scattered atypical cell, we can ignore that. We don't need to call every specimen like these with a little bit of atypical cell as indeterminate diagnosis. We can just call these benign. Okay, so this is considered as a benign pleomorphic adenoma. So then we move to some of the cases that we see last week. So this case was initially like labeled by our cytotech as AGC, atypical glandular cell, which is a very good call. And we determined that by the pattern, it looks like adenocarcinoma with a pattern of extrauterine origin. And the patient do have a history of lung adenocarcinoma. So we destent the specimen and do a TTF1. So at the exact location, you can see the cluster are positive for TTF1. So this is considered with metastatic adenocarcinoma coming from the lung to the cervix. The tumor cells are very, very scant. So it is our cytotech do a very good job to pick up these focus. So we have half of the smear preserved. So we do the cell transfer for the stent. Unfortunately, initially the stent was also like a faded. So we do restent, but it is a little bit difficult to tell now. But as you can still see, that this is adenocarcinoma. Okay, and it is coming from a very, very clean background. Looks like out of nowhere, so we call these alien pattern. And if it is sampled from location, and the smear is usually on the same direction, so you can see there is one cluster of adeno, and along this smearing direction, and there is another one, and another one over here as well. So this is also adenocarcinoma. Okay, so you see prominent nucleolus overlapping with vesicular chromatin glandular pattern. So this is adenocarcinoma, and you compare with the normal endocervical cells, or with squamous metaplasia, immature metaplasia over here. This looks abnormal. Okay, so this is a very classic case of metastasis. So a good case. Okay, let's call it for that. I have two cases to show. So this one is also a pap smear. So the patient had a history of CIN3 and received cone excision and with margin uncertain, margin positive from the outside hospital. So this is the follow-up smear. So after the cone biopsy, usually they would do a 3 months follow-up for 4 times and then move to 1 year. So for this specimen, you can see again, along the smearing direction, they are a typical cell only at the edges of this smear. The cells has very high NC ratio and mostly in cluster and with this coarse chromatin pattern. And here we also see some individual cell like a chorioresis type of pattern. So this is consistent with CIN3. So this is very dark and chromatin pattern. You see coarse granular pattern. And we do not have a lot of single cell for this case, but these cells are diagnostic for high CO. Okay, so this is a typical case for high CO, but we don't have a lot of single cells. And the lesion is at the edges of the slide, so it is not very easy for a screener. If you do not see the entire slide, you might probably miss this. So it is also important that it's already going outside of the slide, you see. So it's important that we see entire slides to identify all the lesions. So this is also a typical case for high CO. Finally, this is also kind of difficult. So the patient had a history of endometrial adenocarcinoma with hysterectomy. So this is also a follow-up specimen, follow-up smear. So when we take a look of the low power feature, it is actually abnormal. So we do see a lot of like a debris and a little bit of blood over here. So this looks actually abnormal. However, some of the cells does looks like atrophy type intermediate cells. So it's a little bit difficult to tell whether these are the previous like adenocarcinoma of endometrium or not, but we do see this atypical glandular structure. The problem for this case is that the nuclear atypia is not very high grade. So it all looks a little bit like, I don't know, like low uterine element or something like that. However, in the background, you do see necrosis. This is a necrotic background. So we do have a concurrent biopsy. So these are atypical cells. And the biopsy shows these are all tumor. Okay, so this was originally interpreted as a reactive change. I was considered this is atrophy versus this is a true tumor. So sometimes the recurrence tumor, this has been proven by the biopsy that most of the cells are tumor cells, actually. So we do not see a prominent two-cell population because most of the cells are tumor cells. So sometimes if the tumor cell doesn't have a very like obvious atypia, that would be difficult for people to call these adenocarcinoma, okay? But these turn out to be, most of the cells are adenocarcinoma. So this is also a good case. So we can save these for the teaching slides. So we have a couple cases today that we want to save for the teaching slides. Just keep these with me first, and I will give it back to you. I need to go to the frozen. Okay, that's it. Thank you.